Let's get started. So we talked about face and neck, now we're talking head and spine. Very similar concepts, but now we're going to be talking more about like the head injury patterns, what we might see. Now, realistically, is there anything we're going to do that's going to fix any of these problems? There's nothing in your scope you can give medication-wise either. But if you can identify or have a good suspicion of what's going on, a couple of things will happen. One, we're going to figure out, is this going to kill them faster or slower? Okay. But then two, we can tell the doctors and nurses, hey, I think this is this kind of fracture because of this, this, and this, and that kind of maybe will guide them. They're still going to do a more encompassing exam, or assessment, that's a better way to say it, but at the same time, we're at least kind of getting the ball rolling, giving them a place to start. So, moving forward. So, if we're talking head and spine, we're talking the nervous system, right? Our brain being the primary organ of our nervous system, with the spinal cord being an extension of that, with an even further extension of our spinal cord being the nerves and the fibers coming off of that. So the nervous system, complex network of nerve cells that enables all parts of the body to function, including brain, spinal cord, nerve, and nerve fibers, okay? None of this should really be news at this point, okay? Now, the nervous system, well protected. Obviously, our brain is encompassed by the skull, which is a durable, dense set of bones designed obviously to protect the brain, with the spinal column, the vertebrae, if you want to get more particular, being protecting of our spinal cord. Now, you'll see the spinal canal. Has anyone ever seen, like, been hiking and they see like a vertebrae, like a cow vertebrae or deer or whatever? If you look at it, there's that hole right through the middle. That's the spinal canal. So if we stack up all of our vertebrae, there's one big long hole or canal that our brain stem, our spinal cord will run all the way through. Now, obviously, no matter how protected we are, we can still hurt ourselves. So they're not perfect. They can still be damaged, okay? So little AMP, we can divide our nervous system into two parts, our central nervous system and our peripheral nervous system. If I think back all the way to like the third class, you guys remember during human body, the two breakdowns of the skeleton? There was this skeleton and that skeleton. Both started with an A. You guys remember what I'm talking about? What is it called? Axial and appendicular. Well, axial, appendicular. Axial was our skull and spine. Appendicular is going to be our periphery, right? So legs and arms. So another portion, we'll talk a little bit about it today, is what's called a connecting nerve cell. Okay, I don't want to go too deep into it because it'll give a lot away, but this connecting nerve cell only exists in two spots, our spinal cord and in our brain, okay? And essentially what it does is it allows for quicker reaction times, okay? More of like, you think about reflexes. That's your reflex, okay? But we'll talk about it here in a moment. So, our central nervous system, our CNS, includes the brain and spinal cord. The brain's going to control the body and is also the center of consciousness, right? Who we are is our brain. And then we can break the brain down into three portions. Now, you can actually break it down way further than that, but for your guys' knowledge, you only need to know the three: cerebrum, cerebellum, and brainstem. Cerebrum is going to be the big fleshy part of the brain you think of when you think brain. The cerebellum is going to be the back of the mind, or the back portion, okay? In this diagram, it always looks like the little fruit there. And then we have our brain stem coming down. Now, I want to draw attention to the pons, once again, the little Adam's apple of the brain stem. That portion will take over breathing and heart rate during fight or flight moments, okay? So, before we get too far, can someone tell me what the cerebrum controls? You're processing, yeah. Conscious thought for the most part. And that's summarizing, right? There's conscious thought, there's movement, like voluntary motion, sight, sound, right? That's all confirmed in the cerebrum. What does our cerebellum control? Movement? A little more refined than movement. What? Basic needs? No.
Things that you have to think to do.
Coordination.
Not quite. The coordination is what I was looking for. Yeah, body coordination. Your cerebellum is why you can close your eyes and still touch your nose, right? I'm not looking at it. I obviously can't see it, but I have that ability to understand where I am. I'm really glad I didn't trip backwards on that. That would have been so embarrassing. Carry on. So, our brainstem, last and certainly not least, what does that control? What's a brainstem control? Bam, critical, necessary to life functions. Breathing, pulse, blood pressure, all those things. So, our cerebrum controls a wide variety of activities, including most voluntary motor functions and conscious thought. Our cerebrum takes about 75% of the brain's total volume, and then we can split that into 2 hemispheres and 4 lobes, right? Frontal, occipital, temporal, parietal. Those are our 4 lobes, and then we can split it down the middle to a left and a right. Now, some of you guys might already know this. What side of my body does the right side of my brain control? The left. So by extension, left side of my body controls what side of my brain? What? Vice versa? Yeah, you knew where I was going. Right. They're opposites, right? Now that's going to play more of a role when we start talking about strokes down the road, but just keep that in mind, right? That's a very relevant thing if we're talking about head injuries. So our cerebellum coordinates balance and body movements, and then our brainstem controls our necessary to life functions, which is also the best protected portion of our central nervous system, which makes sense. If it's necessary for our survival, for our life, it's going to be protected really well. C1, 2, 3, very durable. If you even try to feel your own C1, 2, 3, you got to fight through some muscles and tissues just to feel the vertebrae. It's very well protected, and it's not an accident. Okay? Now the spinal cord is made up of fibers that extend from the brain's nerve cells, which the brain is made up of a combination of what we call gray and white matter. Gray and white matter is accumulations of cholesterol, fun facts. So, by extension, our spinal cord is also made up of cholesterol. Now, our spinal cord carries messages between the brain and the body via the gray and white matter. Okay? And the reason we use, just kind of thinking about it, what kind of signals, or what does our brain use to send signals? Electricity. That gray and white matter is very electrically conductive. It allows us to send messages quick, okay? That's why we want that to extend down our nervous system there. Now, around our brain, we have some protective coverings, okay? The entire CNS is contained within a protective framework, and that'll be the next thing we get into, but you're gonna need to know the layers of tissues that protect our brain from our skull, and I'll talk about them when we get there. Now, the thick, bony structures of our skull and spinal canal can withstand injury very well. And then the CNS is further protected by the meninges. Now, the meninges, we break down into a few different layers, okay? So, how we're gonna break this down is we're gonna think outside to inside. So, from skin, skull, inward, ending with brain, okay? So, the outermost layer, the furthest away from our brain, the closest to our skull, is the dura mater. You can also call it the dura mater. No matter what you pronounce it, it's spelled the same. We know what you're talking about. But the dura mater, tough, fibrous layer that forms a sac that contains the central nervous system. The way I remember it, if it's going to be the furthest away from my brain, and it's my first line of defense for my brain, I want it to be pretty strong. I want it to be durable. Durable. The dura mater is durable. It's furthest away from my brain. It's the strongest first line of defense I have. Okay? Now, working our way in, the next area is the arachnoid mater. Okay, and I'll talk about that here in a moment. So skull, dura mater. Next layer down is the arachnoid mater. And then the last one down is the pia mater. Okay? Pia mater is wrapping around the brain itself. Now, kind of backtracking, what does arachnoid remind you guys of? Spiders. The reason it's the arachnoid mater is because it kind of looks like spider webs. Okay, this orange stringy looking deal here, or orange red, I don't know what color you call it, salmon, I don't know. But that's gonna be the arachnoid space. You might even hear it known as the subarachnoid space. Tomato, tomato, okay? So, looking at it from the outside in, right? Skin, fascia, muscle, skin, muscle, bone, dura mater, arachnoid, pia mater. Okay? You're gonna need to know the layers of these, the order of these layers. And the reason I say that is because we're gonna talk about head bleeds. And if people are bleeding in their head, depending on what layer they're bleeding between is gonna have a different effect. We're gonna see different things. Okay? Now notice also that the pia is going in and out of the creases of the brain, or the folds of the brain, okay? Which, fun fact, the more folds you have in your brain, the more intelligent you are as a species. So if you really want to get under someone's skin and they're not going to know it, call them a smooth brainer, and they'll never figure it out, but they're going to be offended. They don't know why. See, smooth, that's why. Carrying on. So, dura, arachnoid, pia. Now, within our brain as well, or within that space, we have what's called the CSF, cerebral spinal fluid. Now this is produced in a chamber of the brain called the third ventricle, which the third ventricle, let me get to the picture I'm looking for. Third ventricle is kind of this middle space here. Remember, this is just one half of the brain. If we're looking this way, it's the right half of the brain. So this gap in here is the third ventricle. Okay, that's where we make CSF. That's where it starts to circulate. Okay? Now, approximately 125 to 150 milliliters of CSF in the brain at any time, okay? And its biggest job is to act as a shock absorber. When we hit our head, our brain is just kind of hanging out in there. So if I hit my head on my forehead, my brain's gonna go forward, right? It's the same thing as if you have like a ball inside of another ball and you go this way, that ball is gonna go that way, right? And it's gonna slam into the walls of that internal ball. That's our brain and our skull. Okay, and we'll talk about that injury pattern here in a moment. But with that CSF, we're essentially giving it a liquid lining to prevent slamming our brain into our skull all the time. Okay, does that make sense? I lost anybody? Okay. Now, moving to our peripheral nervous system. We have 31 pairs, spinal nerves. Now, they have a couple of different jobs, depending on the nerves. Okay, some nerves are gonna have one job. Some nerves might do a little bit of both. Okay. So some of them are going to conduct impulses from the skin and other organs to the spinal cord. The other one is going to be our motor impulses, so it allows our spinal cord to send messages to our muscles. This is your sensory to movement nervous system. Okay, with obviously our sensory being our skin and organs, right? If we walk outside and it's cold, we want our skin to be like, it's cold, to tell the brain. Brain says, it's cold. To which point the brain will send the muscle message and say, hey, let's go back inside and grab a jacket, right? So sensory input is going to be sent from the body to the brain. Motor impulses are going to allow the brain to interact with our environment. Motor impulses send messages from the brain to the body, okay? Body to brain to body. Make sense? Make sense, Chance? You look scared. Okay, making sure. Okay, so quick picture here, right? So looking at the brain, we have the brain stem and then the spinal cord coming off here. Now, a couple of things I like to draw attention to. Brachial plexus. If you have any intention of going into higher degrees of medicine, you are going to be expected to remember what that actually looks like, what that pathway looks like. But that brachial plexus, that provides sensation to our shoulder. That's the extension of the nerves that go down our upper extremities, okay? That's a big, important area, which is partially why we don't reduce shoulder dislocations out in the field. That's a doctor's skill. One, we could potentially damage, arteries, veins, nerves, maybe even tear tissue. But two, the last thing we want to do is pinch that brachial plexus nerve because that's going to be an abundant amount of pain, squeezing a nerve. And then we have a kind of the inverse. We have the lumbosacral plexus, which is basically the same thing, but it's our lower extremities, okay? I like the lumbosacral because there's a nickname for it called the quada equina. Have I talked about that before? What does equine remind you guys of, anyone? Horse. Quada equina means horsetail. That's underneath our sacrum there, our horsetail. Fun facts. Now, we also have 12 pairs of cranial nerves. You guys are not going to be expected to memorize them, but you are going to be expected to just be aware of them. 12 different cranial nerves. They're going to transmit information directly to or from the brain. Okay, these cranial nerves affect a lot of our face. So the muscles in our face, our smell, our eye motion, our sight. Okay, so they control special functions in the head and face, including sight, smell, taste, hearing, and facial expressions. There is one nerve, though, out of there that I want to draw attention to. When we label our cranial nerves, we label them in Roman numerals, so I want you to write down X. What does Roman numeral X mean? 10. So cranial nerve 10 is the vagus nerve, V-A-G-U-S. Not like Las Vegas, but Vegas, V-A-G-U-S. Okay? Now, the reason I like to draw attention to that one is because that nerve actually ties all the way down into our heart. Okay? And you can actually affect your heart rate with that nerve, but we'll talk about that in a little bit. Okay? Down the road. Like I said, you're not expected to memorize these. If you're going to be raising your scope at all, you will. If that's you, I have a really good mnemonic to remember them, so we'll talk after. Now, there's two types of peripheral nerves. We kind of talked about it already. Sensory nerves, motor nerves, okay? Sensory nerves carry only one type of information, right? So they're going to be It's going to be usually sensation, right, from the peripheral, and that's going to send information to our brain. But even like our eyes, right, that's a sensory nerve, or even like our tongue. Our tongue has a couple. It has a taste nerve because we have that sensation, we have the sense, right, but it also has movement. And then we have motor nerves. Now our motor nerves, there's one for each muscle in our body, okay? And their job is to carry information from the brain to the body. So sensory nerves tell us what the outside world is doing. It's giving us our sensations, our 5 senses there, okay? And then motor nerves are going to allow us to move and interact with our environment. Questions on this at all? Is this making sense? Okay. Now, like I said, we also have these connecting nerves found only in the brain and spinal cord. Now, these connect the sensory and motor nerves with short fibers. It's basically a bypass loop, okay? It allows for the exchange of simple messages, and more often than not, this is our reflex arc, which we'll get into soon. Now, yeah. So those connecting nerves, like I said, they connect sensory and motor. They usually just bypass. So instead of me looking at something, touching something, sending the feedback up to my brain, and then sending back down to move my hand, it allows me to bypass that, okay? Which they'll give a good example here in a moment that I was just about to give away. Can't give away stuff too soon. So our nervous system controls virtually all of our body activity, including reflexes, voluntary activities, and involuntary activities, okay? Which, remember, involuntary, our autonomic nervous system. We don't control involuntary stuff, okay? Versus voluntary is our somatic nervous system. We control our somatic activity, okay? So those connecting nerves in the spinal cord will form a reflex arc. So if a sensory nerve in the arc detects an irritating stimulus, it bypasses the brain and sends the message directly to the motor nerve. It's a lot of fancy words to say it's our reflexes, right? If I touch a hot pan, I don't hold my hand there and be like, yep, that's hot, better move, right? You touch it and it's, oh, we're away immediately. That's your reflex arc. Those connecting nerves skip the middleman, your brain being the middleman in that moment, okay? Does that make sense? Everyone tracking where I'm coming from? Okay. Now, voluntary activities we consciously perform. Involuntary activities we don't control, right? So our somatic nervous system's voluntary. Our autonomic is involuntary, just touching on it again. Autonomic, automatic, we don't got to think about it. We don't have to tell our heart to beat. We don't have to tell ourselves to breathe, right? Which breathing is one that you can bypass. That's one that we obviously can control our breath. But when you're sleeping at night, you're not like, breathe, right? It just automatically happens. Same with digestion. We don't got to tell our body, like, digest that food. It just does it, okay? So the autonomic nervous system handles bodily functions, so divided into 2 sections, sympathetic and parasympathetic. Remember, sympathetic is fight or flight. Parasympathetic is rest and digest. Okay, so in moments of stress, our autonomic nervous system releases what hormone to give us a fight or flight? Adrenaline. What's another word for adrenaline? Epinephrine. Yeah, all the things. We're learning so much, yeah. And epinephrine is a medication in your guys' scope for anaphylaxis, but we'll talk about that later. Okay? Questions at all on the nervous systems and how they function? Any questions on the connecting arcs, anything like that? Okay? So let's get into the skeleton one more time. So our skull, 2 groups of bone, our cranium and our facial bones, right? The cranial bones are going to line up with the lobes of brain that underneath them. And then do I need to spend time in the facial bones? We just talked about them. Cool. Moving on then. So the brain connects to the spinal cord through the foramen magnum. Once again, that's going to be a term that won't go away. Foramen magnum, big hole, base of your skull. 4 major bones: occipital, temporal, parietal, frontal, and then face, maxilla, zygoma, mandible, and then our orbit is comprised of a few bones. Now, our spinal column as well has its own set of bones. You're going to need to know this one, 712, 554, okay? Our body's central supporting structure with 33 vertebrae divided into 5 sections. 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, 4 coccygeal, okay? 712, 554. Yep, 712, 554. If you just remember that order, you're just going to have to remember which ones it's associated with. Now, I know I've mentioned it before, but I like to draw attention to it. Our thoracic cage, our chest cavity, how many ribs do we have? 12. How many thoracic vertebrae do we have? Oh my goodness, putting it together, right? The same things. Just wanted to draw attention to it. So, 7 cervical, 12 thoracic, 5 lumbar, 5 sacrum, 4 coccygeal. Now our sacrum and our coccygeal are fused, right? They're multiple bones that are fused together, so fairly solid. They can articulate a little bit though, okay? Now, injury to the vertebrae can result in paralysis. I feel like that's not news. If you break your back, you can be paralyzed, right? Kind of makes sense. Same with your neck. Now, in between those vertebrae, well, first of all, they're connected by ligaments. They're held together by ligaments, so they stay nice and tight. We don't want separating, right? And then in between each vertebrae, because we don't want bone on bone, we have these little cushions called intervertebral discs. I think of the intervertebral discs as jelly donuts, okay? And the reason I do that is because if you squeeze too far one way or the other, you're going to squeeze the jelly from your donut out. Has anyone ever heard I slipped a disc? That's what it is, right? Or what's the technical term? Not a slip disc. It's escaping me. Ruptured is the word that's coming to mind, but it's gone. It's ruined. Herniated. Oh, there we go. Herniated disc. If we move it to a place it's not supposed to be. And then our spinal column is almost entirely surrounded by muscles. We have a lot of muscles in our back. That said, if we're thinking comparatively to like the front of our torso to the back of our torso, the number may be less, but the muscles in our back take way more space. They occupy a far greater space, okay? Questions on the skeletal system at all? Okay. So let's get into head injuries. So a head injury, traumatic insults to the head that may result in injury to soft tissue, bony structures, or the brain, depending on the mechanism, okay? Now, over half of all traumatic deaths are associated to head injury. And then understand as well, if there's head injury, there could also be associated trauma, right? If someone's not wearing their seatbelt and they hit their head on their windshield, and they star the windshield, is it potential they hit their femurs on their steering wheel or their chest or abdomen as well, right? We got to think beyond just what we're seeing directly, okay? So we can have closed or open injuries. So a closed injury, the brain has been injured, but there's no opening into the brain. So kind of like Carter was asking earlier about a split. If we had split skin, but I can see skull, that's still a closed injury. I know it feels counterintuitive because we can see deeper than the skin, but I can't see the inside world. The difference between a closed and open injury is that if the inside things, the inside structures of our body are seeing the outside world, that's open. That's a problem. If we can't see the inside structures, it's still closed, okay? So open injuries, an opening from the brain to the outside world, often caused by penetrating trauma, and then there may be bleeding and exposed brain tissue. Okay? Brain on the ground is a pretty traumatic thing as well, but we'll talk about that. So, falls and motor vehicle crashes are going to be our most common mechanisms when it comes to head injury. Falls because a lot of older people fall down a lot. It happens. Very, very common thing. I know we all used to make fun of it as a kid, but help me, I've fallen, I can't get back up. That's very real. Very, very real. Old people fall and they can't get back up. And for whatever reason, they like to lead with their forehead a lot of the time, okay? Now, In victims of assault, we'll see them as well. It's also not uncommon to see sports-related head injuries. Been a lot of attention on that, obviously, with the NFL, CTE, things of that nature starting to show up, concussion protocols, but we'll talk about them, okay? And then big, long list of potential reasons to get a head injury. You can spend time on that if you want. It kind of makes sense. Any sort of thing where you hit your head could be a potential head injury. Questions at all so far? Yeah.
A laceration, like a knife to the head, would that be still closed because you can't technically see all the way?
Yeah, so if they just got like cut down the face, still a closed injury. Yep. Okay, so scalp lacerations. A laceration's a cut, right? And so it can be minor or serious. Even small lacerations can lead to significant blood loss, right? Remember, our scalp and our face are very vascular. Not typical for us to go into hypovolemic shock just because it's easily controlled. That said, it can be severe enough to cause shock. Okay, so don't get it twisted and saying, Wade said it never happens. It does happen. It's just easy to control that bleeding for the most part. Now, where we got to look deeper is there a deeper, more serious injury? Okay. When I was in college, in our locker room, we had these, like our sitting locker, then we had an overhead locker. And this overhead locker had like a latch for a lock to go on it, but we all knew each other, so we didn't latch them for the most part. But I had one of my teammates, he stood up and he stood right into that latch and he split his head pretty good, right? And we're all making fun of him, like, oh, you can watch where you're going, blah, blah, blah. Turns out he actually gave himself a minor concussion because he slammed his head into that so hard, right? We're all looking at the small, or the bleeding and the small cut. There's more that behind the scenes, right? So read past the mechanism, read past what you're seeing. The concept of a distracting injury is going to start showing up, okay? Don't be sidelined, or sidetracked rather, by all the gore and blood and the things that is like, ooh, that looks very wrong. A lot of those things tend not to be the root cause of the problem, or a life threat is a better way to phrase it. Okay, some of them are just, they look graphic. Now, skull fractures. Significant force applied to the head may cause a skull fracture. It may be open or closed, depending on whether there's an overlying laceration of the scalp, right? But injuries from bullets or other penetrating, injuries from bullets or other penetrating weapons are often will result in skull fracture. If someone's shot in the head, they got to break through that skull. That's a skull fracture, right? It's going to be associated. Kind of makes sense. So, some signs of skull fracture. Patient's head appears deformed. We have visible cracks. We have ecchymosis. You guys remember what ecchymosis means? It's kind of like there's contusion, hematoma, and then the top one's ecchymosis. Do you remember when we were talking about reasons not to start CPR and it was the picture of that person's back and they're all purple?
Oh, wasn't it like blood pooling?
Yeah, it's blood pooling. So like in dead bodies, it's all the blood leaving the organs and it's going to settle no matter where they're at. But we can see blood pooling if they have a crack in their skull, blood's going to be coming through, okay? So a couple of signs, these ones are going to come up. If we have ecchymosis under the eyes, that's called raccoon eyes. That's indicative of a skull fracture. The next one, I told you to remember mastoid process, right? The part behind our ear. If we see ecchymosis behind the ear on the mastoid process, that's called battle signs. So raccoon eyes, battle signs. Both indicate skull fracture. Okay? With a couple of examples. Now, obviously, that's a pretty extreme raccoon eye picture there. Okay? Now, things we got to consider. The mastoid process there. Do you think the only bruising we're seeing or only pooling we're seeing is just what we can visibly see, or is that going deeper than what we can see? Yeah, it's going to go past, right? It's going to be buried in that hair. Make sure you're spending time, go through the hair, see how much ecchymosis, how much pooling is going on. It's obviously going to be a little bit tougher, but you're going to have to go through. There's a reason when we talk about secondary, which we'll go through a little more thoroughly later, I want you to look at the scalp. Sift through the hair. Look at their scalp, because people cut their head, hair on their head, hard to see it. People break their skull, bruising behind the ear, tough to see it. Okay? Now, different types of skull fractures. We have our linear skull fracture. This is about 80% of all of them. Okay? We are obviously not going to be able to diagnose this because we need x-rays. Okay? But radiographs required to diagnose a linear skull fracture because there's no physical signs. People hit their head, they have a line usually coming off those fusion points in our skull. amongst those different bones are called sutures. It's usually running along those sutures to some degree, either perpendicular or parallel with. Okay, but this is one that we're not going to see physical signs of. Depressed skull fractures, on the other hand, you may. So depressed skull fractures result from high energy direct trauma to the head, usually blunt. Okay. Frontal and parietal bones are our most susceptible. So frontal, forehead, parietal being these back corners. And then if we're not careful, right, depending on the force, those bony fragments can go actually into the brain themselves. Okay. Now, one thing I just want to draw attention to, and you'll see why this is relevant when I'm done with these slides, is that in our frontal bone, we have a cavity right here, big hollow cavity. Does anyone know what the cavities in our face are called? You get infections from time to time, makes it hard to breathe. Sinuses. So we have sinuses in those bones, okay? You have a big one in your frontal bone, your frontal sinus, okay? Now hold on to that. What a sinus is, it's a hollow space. So there's bone on one side, bone on the other. You'll see why it's relevant here in a moment, okay? But versus the parietal areas, we don't have that big sinus. So we run the risk of bone fragments going into the brain. Now the next one, basilar skull fractures. These are high energy trauma, okay? Usually following a diffuse impact to the head. They got hit and struck in the head pretty hard, okay? Now this one, the basilar skull fracture, is where we're gonna start to see CSF, raccoon eyes, and battle signs. So you'll have CSF leaking from the ears, maybe the nose, the raccoon eyes, and then the battle signs on the back of the head. Those are signs of basilar skull fracture. I would remember that one. Basilar skull fracture, CSF, which the halo test, remember that's how we're gonna gauge, raccoon eyes, battle signs. Okay? Questions on this at all? And then the last one, open skull fractures. So usually there's going to be a lot of trauma to multiple systems, but brain tissue may be exposed to the environment, right? That's an open, the inside world seeing the outside world, and it usually has a high mortality rate. Okay? Now, brain on the ground, there's a couple of things we got to know about it. First of all, if we show up and we see brain matter on the ground, that does not mean that patient is dead. That doesn't mean immediately we're like, chalk them out, right? We got to check them. Do they have a pulse? Are they breathing? Right? If they have a pulse or they don't have a pulse but they're still breathing, we can still try CPR. We have to run CPR for at least 20 minutes on every patient we find down, okay? That said, there are going to be times when you show up and there's so much brain matter on the ground, at that point your job is to try and keep that body alive for potential organ donation. There was a kid last couple years ago now, over by Meridian High School, and this ties into multiple body systems. Was crossing the street going to school. Something happened where they decided they were going to go back the way they came. Ended up getting hit by one car into another, into another. I talked to the providers who were there, and they said there was so much brain on the ground they had to wash their boots after. Okay, it can be really, really traumatic. Obviously, that was one where they showed up and there's no sign of life potential in this kid. But keep that in mind. Just because there's brain on the ground doesn't mean we're not doing anything, but it does mean we're going to have to take a closer look at our patient, okay? Questions at all on skull fractures? So, story time. When I was in college, me and a couple of my buddies, we played college soccer. We were from here. We all lived together. Well, when you're an athlete at school, they don't let you play intramurals because if you hurt yourself, there goes your scholarship, right? So we would finish the season. I had graduated from the program at that point and still in school, so I was like, screw it, let's go play intramurals. Sorry. And so we went and played intramurals, and we were playing basketball. Now, if you've ever played intramurals, there's always one kid who's trying really, really hard. It's like when you're in gym class, there's that one guy doing the absolute most. So we were playing basketball. We were losing really bad. Soccer players, basketball, not a good mix. So the ball rolled to my buddy, and he bent down to pick it up. As he picked up the ball, the try-hard decided he's going to dive. They ended up clacking heads. And it made this sound. If you've ever heard someone break their nose, it made the breaking nose sound. It's a loud, cracking, crunchy sound. Well, this kid's basically my little brother because his older brother's one of my best friends. He's been my best friend since we were like 12. And I look at him and was like, do you want to deal with this? Do you want me to deal with it? And he's like, I'm sick of him. You deal with it. It's like, okay. So I walk over there and everyone's huddled around him. And I'm like, so what's going on? Are you bleeding? No one's saying anything. And he gets up and he's being tough. You can tell he's kind of got tearing, which I thought he broke his nose. So I was like, well, that checks out. We ask him if he's okay. He says he's okay. We go home. So then he was dating a girl at the time who lived in Moscow. We went to school in southern Utah. So he was hopping a flight to go there. When he arrives, he sends me a picture. And he's like, hey, real quick, is this normal? And I said, if you're referring to the big old dent in your forehead, I'm going to say no, and you should probably go to a hospital. And he said, yeah, I'm going to do that when I get back to Utah. It's like, okay, that's responsible. So he ended up staying the weekend, like 4 days in Moscow before flying back down. Well, unbeknownst to me and his brother, my roommate, that he had been bleeding all night, and he didn't tell us. He'd been bleeding into his throat. He'd thrown up several times because he's swallowing blood. Well, turns out he had a frontal depressed skull fracture. So what I thought was his nose breaking was actually his skull. Now this is where I mentioned that sinus is important. He's really, really lucky that where he broke was in that sinus. So he never, with him being gone for a whole weekend, he didn't run the risk of running bone into his brain because he still had an internal layer of bone available. Okay. Now one thing I like to point out in this picture, this is where the fracture is, right? Where do you think his face is?
It's on that side.
Yeah, his face is here. So what they did is they split him from ear to ear and they pulled his face down. Yeah. He has a pretty gnarly scar that goes from ear to ear. And then from time to time when he's pissing me off, I ask him what he's listening to in those fancy headphones of his. And he does not like that joke, but that's showbiz. So he had a depressed skull fracture. So what they ended up doing is they ended up putting a titanium plate on him. I asked, they don't set off alarms, which is a little disappointing. But he's gonna have that for the rest of his life. That's holding that bone together, essentially. So what they did is they went through, they pulled all the chips out, and they basically puzzle pieced this together and then screwed that plate in while securing it to bones.
It looks like the actual break in the bone was higher up though than the actual.
It was right above the orbit there.
So that's literally his forehead right there.
That's literally his forehead right here. Yeah.
Shouldn't his eyes literally be like right there?
Yeah, his eyes are like right in here. Yeah, he was fortunate that when he broke it, because where we were in St. George, Utah, is one of the most notable surgical centers in the country. The #2 plastic surgeon in the country just happened to be there that weekend, so he got a surgery done by someone who knew what he was doing. Yeah, plastic surgeon did it. No, which a lot of times plastics plastics ends up being like a secondary. So like when I got my nose fixed, he was a EMT surgeon, but he also had his minor or his second residency fellowship. That's what I was looking for. Yeah.
So the top of his head on the bottom of the screen.
Yeah, this is the top of his head right here. So everywhere under this towel, this is where the rest of his hair and scalp is. They're holding the towel there to hold the hair back. And then I like to include this picture because I think it's kind of goofy, but this is when he had 2 drains coming from it because you obviously don't want blood. They look kind of like this at the end, so they were just pooling up and holding a bunch of blood. His brother, like I said, one of my best friends, he's a chiropractor now. This was a moment that I just confirmed that I make some dumb friends from time to time. Because he was on a bunch of pain pills, because obviously his face just got folded. He was on a bunch of pain pills, and so when you're on opiates, it makes you constipated. That's a side effect. So they put you on a stool softener to help you poop. So he lived in the upstairs. Me and his brother lived in the downstairs, like on this side of the apartment, like over here. And he was going upstairs, and he's like, hey, can you grab me that stool softener? And I watched his brother grab the pillow off of the stool of our countertop and walk upstairs, only to hear him be like, are you an idiot? And then walking back downstairs with his pillow. It was really, really funny. I just like to include that detail because it's always good. So yeah, that's my personal experience with skull fractures. Personal from afar, which is the best way to experience skull fractures, I've come to find. But yeah, so like I said, very fortunate that he had that layer of sinus, because if he was gone for 4 days, sleeping in a random bed, flying on an airplane, pressures changing, he could have been wedging bone deeper and deeper into his brain. May have made him smarter, I don't know, but you just never know. You never know. Okay. So moving into the next one, TBIs, traumatic brain injuries. So these are going to be the most serious of all, or rather, going back, any questions on skull fractures? Sorry, I didn't take the time to ask. Cool. Questions about the story at all?
I do have a question.
Okay. Yeah.
When they like fold his face down, does that not cause any like that like smushing everything in his eyes and like his nose and it's all getting smushed?
Soft tissue. It's soft tissue, so it wasn't heavy enough to start mushing him. Yeah. Good question. That was a good question. Okay. Any other questions?
How do you not know that you fractured? Like,
So it had swelling. It had swelled up so bad that it looked normal for us. Yeah, which I should have put 2 and 2 together. that, you know, was like, well, your nose looks fine, you know, and I didn't put two and two together until I was like, oh, dang it. Like hindsight's 20/20 on that one, huh? Yeah, but swelling, that's where swelling can make things difficult. Remember when I was saying they'll put ice on it to bring swelling down so doctors can do a good assessment? That's exactly why, because you can miss big things because of swelling. Okay, moving forward now. So traumatic brain injuries, most serious of all of them, of all the head injuries, excuse me. Now there's two broad categories. There's primary injuries and secondary injuries. Okay, so primary injury is going to be primary brain injury results instantaneous from impact to the head. They hit their head. There's some damage done. Now the secondary injury increases the severity of the primary injury. Now the secondary injury isn't like they've been thrown from one car to the next car to the next car. The secondary injury tends to be things like hypoxia. They hit their head hard enough now they're losing oxygen in their brain. Or they're bleeding maybe in their brain and their blood pressure's dropping. Okay? Or they have fluid building up, cerebral edema. Okay? Edema just means there's fluid somewhere there shouldn't be. Okay? So there's excess fluid in the head. Maybe they're bleeding inside the head, intracranial hemorrhage, which is going to cause ICP, increased intracranial pressure. Write that down, highlight it, circle it, stamp it to your forehead. ICP, intracranial pressure. Does not stand for insane clown posse. It is intracranial pressure. Okay? You could have cerebral ischemia. Ischemia is essentially, we'll talk a lot about ischemia later, but you're pinching off blood supply, which if we're pinching off blood supply, we're hypoperfusing an area because sugar, oxygen, waste removal happens through our blood. And then infection can be a secondary. Okay? Yes? Remember, you have access to all these slides, Carter. So I'm going to give you until I'm about halfway in front of your tables. You better start writing fast.
I just need the ICS.
Oh, ICP. ICS, different. Okay, everybody good? Am I good to move past this? All right, so the next one. The brain can be injured directly by penetrating objects, right? Duh, getting shot, stabbed in the head, or indirectly as a result of external forces. So this next one, coup contra coup injuries, this is a pattern you're gonna need to know for your not only your benchmarks, but the NREMT exam. A coup contra coup. So remember, our skull is the barrier, our brain is not free floating in there, but it can still slam back and forth. So what a coup contra coup injury is, more typically we see it in motor vehicle collisions, someone not wearing their seatbelt. They come to an abrupt stop. We'll say they hit a tree. That's a pretty abrupt stop. From that point, they're going to fly forward. They hit their head on their windshield. Well, when they hit their head, they're going to hit the skull, obviously, but their brain is still launching at that same speed. So they hit their head, their brain hits their skull. Well, what goes forward, what's stopped, is going to go back. So as they fall back and they slam their head against their headrest, the brain's going to follow and it's going to go right back. So basically, you're shaking their brain back and forth against their own skull, okay? This is why I'm sure you guys have heard it, shaken baby, right? Or partially. If you shake a baby, their brain is rattling off their skull. It's going to cause some damage and can potentially kill them, okay? High likelihood. But head hits windshield, brain comes to an abrupt stop by striking the inside of the skull. Head falls back against the headrest, brain slams into the rear of the skull, okay? Your skull is playing tennis with your brain back and forth. Now, cerebral edema, the fluid buildup, may not develop for several hours, okay? With low oxygen levels aggravating that cerebral edema, it's just gonna make it worse, right? If the brain's becoming hypoxic and now we're putting pressure on our brain because there's fluid buildup, it's gonna get less oxygen. Remember, our head, just like the rest of our cavities, are designed to hold exactly what it holds. So if we start introducing other things, blood, fluid, that's going to increase pressure. It's going to start pinching on things, okay? Kind of like a tension pneumo, if we can tie two and two together from shock, okay? Now, monitor the patient for seizure activity. That's not an uncommon head injury finding, okay? Sign, if you will. We'll talk all about seizures. Seizures can sometimes be the problem. Sometimes they're a symptom associated with a bigger problem. Your job is to figure out, is this because they hit their head they're seizing, or are they seizing because they just had a seizure, okay? And it can be tricky. I had a gal, we'll talk about her, well, I'll talk about her now, and she'll probably come up again later. She slammed into, it was in Meridian, she ended up hitting a stopped Idaho F350, or Idaho Power F350 truck, and she was in like a 1980s Datsun like basically the old Toyota Tacoma, 2 single cab, so only 2 seats. When we showed up, her engine block was in her passenger seat, and she was really, really out of it. Because we showed up, they scooped her, we were gone. And so in the back, she was awake, but she was looking at us and was like, I can't, what's going on with you? And, you know, thinking she hit her head, she for sure was missing a bunch of teeth. There's blood in her mouth. I was like, awesome. This is messy. Well, she started to seize after. And so once we get the meds on board, we get her stopped to seizing, we get to the hospital, everything's hunky-dory. Well, fun fact, or not fun fact, but ironically, I guess I'll say, 3 weeks later, I was dispatched to a house for foot and rib pain. Turns out it was this lady. And I was like, oh, well, what happened? She's like, well, I have a seizure disorder. So what had caused the wreck was the seizure, not her hitting her head causing a seizure. So sometimes this can be difficult to play that game. I only got closure because I ended up seeing her again. I also got closure. I was like, hey, just curiosity, did you lose any teeth? She's like, no, why? I was like, oh, okay, cool. Only had 8 at baseline, like good to know. So try not to be judgmental. Not everyone has all their teeth all the time. But I didn't see any teeth floating around in her mouth or around the area, so I didn't really know. But keep that in mind, seizures can be associated or they can be the problem. It really depends on the circumstance, okay? Okay, so ICP, intracranial pressure. Once again, our head is designed to hold our brain and our brain stem, nothing else, okay? Well, and the fluid and the things that are supposed to be in there, okay? But accumulations of blood within the skull or swelling of the brain can lead to an increase in intracranial pressure. There's more and more pressure put down on the brain because now we're trying to fit a lot of stuff into a small thing. I had a guy tell me one time, it was not in relation to anything medicine, it was about a tattoo, but he's like, don't fit 5 pounds of poop into a 1 pound bag. It's the same idea. You're trying to fit 5 pounds of poop into a 1 pound bag, the 1 pound bag being our brain, the blood being the extra pounds, okay? But that increased ICP squeezes our brain against the bony prominences of our cranium. So we're pushing our brain over and mashing it up against our skull, okay? Well, has anyone ever like pressed their hand against something for so long that the vasculature closes and your hand gets cold? You're doing that to your brain. You're cutting off blood supply to your brain everywhere that it's mashing up against your skull, okay? So, some signs, symptoms we'll see. We talked about Beck's triad last time, right? Muffled heart tones, JVD, hypotension. ICP has its own triad as well. So the first thing is Cheyne-Stokes respirations. Cheyne-Stokes respirations is a pattern. It's a rhythmic loose term, pattern of breathing. Essentially, this person starts breathing really, really fast because their body is starting to panic. They don't know what's going on. They're breathing fast. Well, if we're breathing fast, what do we breathe off? Yeah, CO2, right? Well, what stimulates us to breathe? CO2. So we breathe off all of our CO2, then the body says, whoa, 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 we have no CO2. We need to let that build up. So they go from really fast to so slow they're almost apneic. Well, at that point, they're like, whoa, 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 we got too much CO2. And then it's a back and forth pattern, okay? Another one you might see is ataxic breathing, otherwise known as biots. They're slightly different but similar. When we breathe, we like it to be in a normal, regular rhythm. Inhale, exhale, right? Ataxic or biots breathing is there's no regular pattern. It's inhale, exhale, inhale, exhale, inhale, exhale, inhale, exhale, inhale, exhale. It's random, okay? Now, the real difference between ataxic and biots is that ataxic is strictly rhythm. Biots is a mixture of rhythm, but then the depth of their breathing. They might have a deep breath, and then a shallow breath, and then a shallow breath, and then a deep breath, and a regular breath, and but it's in that weird rhythm as well, okay? Now, you might also see decreased pulse rates, headache, nausea, vomiting, decreased alertness. You guys are gonna come to find nausea, vomiting is not gonna be a reliable symptom set. There's a lot of things that make you vomit, okay? But decreased alertness, bradycardia, sluggish or non-reactive pupils. I'd even throw anoscoria in there, okay? Decerebrate posturing, okay? Decerebrate posturing. Now, I'll talk about those in a second. I'll come back to it. And then the last one is a widened blood pressure. What does a widened blood pressure mean? Do you guys remember when we were talking pulse pressures? What is that systolic number doing?
It's going up.
It's going up, right? Because the difference between our diastolic and our systolic is getting bigger. It's widening. Now, a couple things. Cushing's reflex, otherwise known as Cushing's triad. Here we go. This is one you're going to need to remember, stamp in your brain, burn it to your forehead. Is hypertension, or you can also in parentheses put widening blood pressures. But hypertension, bradycardia, so slow heart rate, and then the last one is irregular respirations. Okay, they're in a weird breathing pattern. So hypertension, bradycardia, irregular respirations. The way I thought about it, it's a little goofy. If it doesn't work for you, it doesn't work for you. But I always thought of Cushing's as inverse compensatory shock. If our blood pressure is dropping in normal shock, what does our body do to compensate? If our blood pressure is dropping, it'll constrict, but what happens to our pulse rate? It goes up. Blood pressure drops, pulse rate goes up. Try to find that middle, okay? I think of this as inverse compensation. Our blood pressure gets really high, and so our heart says, whoa, well maybe we'll just slow down, which is obviously not a conducive thing for our body, okay? That's how I think of it. If that doesn't help you, I'm sorry, but it's just one thing to maybe look at it. Now, I found a good video of Cheyne-Stokes respirations that I wish I would have seen before I got out in the wild and saw it in person, and it was a lot scarier. This guy.
Here in West Boise, we care about our...
Shush. Okay, so watch his breathing, right? He's got a rapid breathing, starting to slow down. Oh, nope, sorry, we were in the slow. Now we're breathing fast. Rapid, lost too much CO2. Time to start slowing down. And then they're almost apneic. Oh, got to build it back up again. You guys see that pattern? That's Cheyne-Stokes breathing. Cool. Questions at all on ICP so far? You're going to need to remember Cushing's triad. Beck's triad, Cushing's triad. Remember what they're for. And when you guys start getting questions, because this is the test, or excuse me, the benchmark that normally slaps people in the mouth a little bit. It's not like the foundations benchmark where you can just memorize something and slap it back on my page. Now you're looking for the what, why, and how. What am I seeing? Why is it happening? How can I fix it? Or how can I help, right? Because we can't fix a lot of things, okay? So it's gonna be a little bit different. I want you guys to be able to go through a question and it says, you discover a 39-year-old female who was in a car wreck, hit her obvious starring on the windshield, indicator she hit her head, right? You see an abnormal breathing pattern, bradycardic pulse rate, hypertensive pressure. That should immediately be like, that's Cushing's. This is ICP, right? You should be able to put things together very, very quickly. Now, another thing that can cause ICP is intracranial hemorrhaging, right? Bleeding into our head. We're adding things to the ingredients or to the list that we don't want on the list, okay? So bleeding can occur between the skull and the dura mater. This is why you need to know those meningeal layers, okay? Between the skull and the dura mater, that's going to be an epidural hematoma or an epidural bleed. It can happen beneath the dura mater, but outside the brain, okay? Now that one I'm going to go into a little bit more clarity. You'll see why, because there's a couple of different examples. And then the last one, within the brain tissue itself. That's intracerebral hemorrhage. The brain itself is bleeding. Okay, so going to the epidural. Accumulation of blood between our skull and the dura. The blue is the dura mater. Okay, nearly always the result of a head producing a linear fracture. Now, there is an identifying symptom of epidural hematoma. Hint, hint, wink, wink. You're going to want to remember this. It is a lucid interval. L-U-C-I-D. Lucid interval. What that means is these people are going to hit their head. But if we think about where this is in the brain in conjunction, it's going to take time for that pressure to build, right? Because it's far away from the brain. It's going to take time for it to build up. So that lucid interval, the patient is going to seem fairly normal, maybe a little confused, but fairly normal. And then as that pressure increases, they'll start having more and more symptoms and signs that we'll see. And sometimes it turns into stroke-like presentations, okay? So epidural hematoma categorized by a lucid interval. That is our sign symptom of recognition, okay? The next one, is a subdural hematoma. A subdural hematoma is below the dura mater, but even more particularly, a subdural hematoma is below the pia mater. So remember, it's dura, arachnoid, pia, and then brain. A subdural hematoma is typically beneath the pia mater, but between the brain. Okay? Now, accumulation of fluid beneath the dura mater, but outside the brain, occurs after falls and injuries, often involving strong deceleration forces, so people hitting their head, okay? And there may or may not be a skull fracture associated. Depending on time, I have another story regarding this and some pictures. We'll see if we get into it. There's not a lot you can see. It's not as good as my surgery pictures. I can't see the skull. But it is a good example of extreme swelling that'll happen after these kind of injuries. Questions on this at all so far? Okay. Now, intracerebral, bleeding within the brain itself, okay, so can occur following a penetrating injury to the head or rapid deceleration forces, right? So once again, stopping, going fast, stopping quickly, hitting your head. This is why you wear your seat belts. I don't care what arguments you're gonna make. They're uncomfortable. I don't care. They keep you alive. Wear your seat belts. I can tell you the amount of people I picked up who were alive when they were wearing a seatbelt, and I can tell you how many of them weren't when they weren't, okay? Wear a seatbelt. And lastly, subarachnoid hemorrhage. So we can bleed into that arachnoid space, okay? Now this occurs in the subarachnoid space where we have that CSF circulating. That's where that circulates in our brain, okay? Which is gonna result in bloody CSF, maybe signs of meningeal irritation, so you might have some altered mental status, maybe level of consciousness is gonna be disrupted. With the common causes being trauma or rupture of an aneurysm, okay? So, questions on that? Let me double check something. I wanna see how much more we have, because if we have a lot more, I'm not gonna stop and show the pictures. If we don't have a lot, then we'll be good. Whew, well, it just keeps going, doesn't it? Cool. I'm not gonna stop and do it, but I'll tell the story real quick, and then if you're interested after class, we can stop and I'll show you the pictures. But my mom was in a car wreck a couple of years ago. She was a passenger in the back seat of a vehicle. It was in North Carolina. It was dark, no lights. They ended up it was downpour raining. They ended up hydroplaning as they were going the opposite direction of a state trooper who also hydroplaned. They ended up having a head-on collision. My mom thought it would be a good idea to put her forehead through the passenger window. She ended up having a subarachnoid bleed. She's okay, there's no deficits, everything's fine. But her forehead swelled up giant, and they actually ended up having to cut it so that they could relieve some of the pressure in her skin there. She's fine now, so there's all sorts of jokes being made, a lot of beluga whale references. I convinced her to be a cyclops for Halloween last year, it was great. But not great things, but we'll talk about it and I'll show you the pictures after. Okay, questions on ICP at all? You're gonna need to know Cushing's, it's gonna come up. That's one that I was also included in my Ada County testing. They wanted to know the triads, okay? So wherever you go, that could be up for grabs. Moving on, so concussions. A blow to the head or face may cause a concussion of the brain. Closed injury with temporary loss or alteration of part or all of the brain's abilities to function without demonstrable physical change to the brain. So what this means is they hit their head so hard, their brain hit their skull. There's nothing wrong with the brain's function, they're just a little confused. They're a little bit out of it, they kind of shook themselves up, okay? About 90% of patients with a concussion do not lose consciousness. They used to grade concussions because of consciousness or loss of consciousness or no loss of consciousness. Not really the case anymore. Okay, they kind of did away with that. Now, a patient with a concussion may be confused or have amnesia, and usually a concussion lasts only a short time. Okay, I had a patient, one of my favorite stories to tell. I had a patient who, we picked him up at a psych facility. It was a fall, he hit his head. When we showed up, nurses were like, he's got a low blood pressure. Well, they kept him sitting up with a low blood pressure, which that's not good math. And so I was looking at him, he had a cut on his forehead. They're like, yeah, he hit his head on the table. Look at the table, there's blood, there's the trail, story's adding up. Now, once again, they left him sitting up. So as we were turning around to grab our stuff, the nurse decided she was gonna let go of him and grab something else. To which point, yeah, he took a tumble, took a clack off the floor. Not great. It made our job a lot harder in that exact moment. But where he became one of my favorites was that he ended up having a concussion. And when people have concussions, they're kind of on a 5-minute reset loop. Every 5 minutes, they kind of forget what's going on. So he comes to, he's a really nice guy. Like, what happened? We explain it. He's like, okay, cool. It's like, can I ask you a question though, without you getting mad at me? I was like, yeah, man, of course. And he's like, aliens. And then he just stopped talking. Like that was the most normal thing in the world. I was like, okay, sure. And then the next question, can I ask you a question? Yeah. Was I abducted? No, man, you weren't. It's like, oh, thank God. Well, every 5 minutes, those same questions. Can I ask you a question without you getting mad at me? And then it got to the point where me and my partner are like, aliens? He's like, how do you know? Right? And then he's obviously not trusting us at this point. Was I abducted? Maybe. Oh my God. Like he's freaking out, right? So, and then finally we get to the hospital and we give him the report. And so just keep that in mind. Every 5 minutes or so, or depending on the person, depending on the amnesia, they can have their reset loop. I've seen it a time or two. Now, there is another term. With amnesia called retrograde amnesia. Okay, so essentially it's like someone's driving somewhere, they get in a wreck. And you're like, hey, what's going on? Do you know what happened? They're like, no, I don't know what happened. Well, what were you doing? Well, I was driving to go see my friend, but I don't remember what happened. That's known as retrograde amnesia. They can remember what happened in the past because retro is a throwback, right? Retro is in the past, in the back, because we also have a retroperitoneal for kidneys, but digressing. So keep that in mind. That is one that will come up as well, retrograde amnesia. So symptoms and signs to ask about with our concussion patients. Dizziness, weakness, any changes in vision, nausea, vomiting, tinnitus, slurred speech, inability to focus, okay? Slurred speech also has its own med term, that's dysarthria, okay? Dysarthria. But that'll come up again later when we talk about strokes. Questions on concussions at all? Okay, moving forward. Yeah.
With ringing in the ears, is that considered tinnitus or is that different?
Ringing in the ear is, yeah, so is ringing in the ear considered tinnitus? They're the same thing.
No matter what.
Yeah, they just tend to use layman's terms on the slideshows on the off chance. Yeah. Okay, so a contusion. This is more serious than a concussion. A contusion is a bruise on the brain. Okay, so this is a physical injury to brain tissue. Now this one, they can sustain long-lasting or even permanent damage, because if the bruise is taking up space on the brain tissue, well, that's space that's not going to be perfused very well because there's a mass that's now taking up room. Okay, to which point they may exhibit any or all signs of a brain injury. Okay, now for us lay people, we show up side of the road, someone wrecked their car. Are we going to be like, concussion? It's a contusion, right? We're not going to be able to tell the difference. You're going to take them to a hospital. Nothing changes in our care outside of our potential suspicions, right? I like to think at the end of each call, I want you to, if you don't know for sure what's going on, have at least 2 to 3 educated guesses, right? Could be a concussion, could be a contusion, could be a subdural hematoma. I don't know, making it up, right? But think about it that way. The more options you can give yourself about what could be happening based on what we see, that's going to open a few doors for you. Okay, so other brain injuries. So blood clots or hemorrhages, both of those fall under stroke, okay, but we'll talk about those later. Now, signs and symptoms of non-traumatic injuries are often the same as those of traumatic brain injuries, okay? A lot of it's going to be mentation changes, blood pressure drops, okay? Stroke-like signs, facial droop, arm drift, slurred speech, okay? And we'll talk all about those later. But they tend to look the same, okay? Or very similar anyway. For spine injuries, we have compression injuries. These typically happen as a result from a fall. Someone jumps from a high space and they land on their heels, send all that force up their spine, squishing the jelly donuts, okay? Force that can compress the patient's vertebrae can cause herniation of disc. All right, everyone tracking my jelly donut? Okay. Now, motor vehicle crashes can also overextend. Anytime we overextend our spine in any direction, we run the risk of hurting ourselves, right? We bend until we break. And even bending to certain extents can cause damage. Our spinal cord and our brainstem are very, very fragile. They're very sensitive. So it doesn't take a lot of trauma to truly damage them. Even just twisting or nicking the spinal cord can cause lifelong deficits, okay? And then rotation flexion injuries of the spine usually result from rapid acceleration forces. So like you're looking back, right? You're grabbing something from the back seat, and then someone hits the gas, and you do that number, right? Puts the risk of damaging your spine as well. Anytime you're torquing yourself into a weird position. When the spine's pulled along its length, right? If they pull us long ways, if you think about like the medieval torture rack, right, where they separated you, which in that your arms and legs would go first, but I digress. But that's pulling on your spine, right? Hyperextending, pulling the spine along its length, cause some damage. But any one of the unnatural motions, as well as excessive lateral bending, can result in fractures, which then can result in a neurologic deficit. Remember, a neurologic deficit isn't always a brain injury. Paralysis, being paralyzed, is a neurologic deficit, okay? And then when bones of the spine are altered from dramatic forces, they can fracture or move out of place. There's all sorts of different patterns of spine fractures. We're not going to talk about them in here. But there are some where if you break a piece off, same as like with a depressed skull fracture, if we depress it and skulls going into our brain, you can have the same effect of spine going into the spinal cord, having your vertebrae themselves actually rupture or lacerate your spinal cord. Question with spine injuries at all. The majority of this lecture was for head injury type stuff, okay? But spine injuries are very relevant. We do see them from time to time. Okay, assessment. Let's read the mechanism, okay? These are just examples. We're kind of running low on time, so I'm going to skip through some of these. You guys can spend time in your book, right? But anything that could potentially cause harm to your head or back, which the list is pretty long if you think about it, okay? So I'm going to move our way through. I will say with axial loading injuries, that's like squatting, like putting a lot of weight on your shoulders and like loading up your weight onto your spine. And then diving accidents is a pretty common neck injury. I've seen a couple of pages of like groups for people who have been paralyzed for one reason or the other, and a lot of them were diving into that 3-foot pool, which is why you see the no diving sign. Okay, so scene size up, make sure you're paying attention to your surroundings, keeping yourself safe. Big one I will say, if it's motor vehicle related, give the fire department time to stabilize that car. The last thing we need is you going in there trying to help and then that car rolls over and squishes you. Okay, make sure you take the time to stabilize it. Read the mechanism, ABC stuff, XABC. We're going to be using backboards and C-collars quite a bit. Okay, lots of them. Okay, manner of transport I will stop on. If we're worried about head, neck, spine involvement, they need to be supine. That's just the best way to manage them, okay? And it's the way that's going to cause the lowest amount of potential damage to their neck or spine. That way we're not manipulating them, rotating them too much, okay? History, if it's relevant, ask the questions, OPQRST sample. Secondary, so this is going to be our systematic head to toe or the focused. We'll talk about both later. Systematic head to toe, start of the head, you're going to touch everything, including the back, okay? Focused is exactly what it sounds like. You're going to focus in on whatever's hurt. But we'll talk about them. DCAP, BTLS, make sure you're checking CMS. That's another one actually we'll stop on. Make sure you're checking CMS, especially if we're worried about a spine injury, right? Because what's a side effect of a damaged spinal cord? What happens when people break their back? Paralysis. Yeah, so we can check sensation. If you have someone who has got a spine injury, what I used to do is I'd take a needle, I would take my IV needle, and I would just scratch them, or you can use a pen. I'm going to scratch them. Tell me when you can feel where I'm touching. And I'm going to slide up their leg or arm, wherever they can't feel. And as soon as they're like, oh, I can feel it there, take a Sharpie, mark the spot. Then when you reassess every if they're paralyzed 5 minutes, you're going to check it again. And if you're past that black line, they're like, oh, I can feel it now, right? You're going to see that regression of sensation. You're going to see them become essentially more paralyzed. But it's something we got to keep track of, because then the neurologists, when they get involved, they can kind of do some more looking and figure it out. Look for CSF, right? Nose and the ears. We'll talk about GCS scores later as well. This is going to be one that I'll give you the table when it comes to your assessments, but we'll talk way more in depth about GCS in a bit. Reassess every 5 to 15, which more than likely, if it's going to be a head injury, it's going to be 5 minutes. Oh, okay, I didn't talk about one thing, and I want to talk about it real quick. 2 different kind of what we call posturing, okay, posturing. There's decerebrate posturing and there's decorticate posturing, okay? Now, out of the two of them, decerebrate posturing is worse. Decorticate posturing, not good, but it's better than decerebrate. Does anyone watch UFC in here? Any fight fans? You ever see when people get knocked out and they do this number and their hands and feet kind of curl inward? That's decorticate posturing. Okay, the way I remember it, decorticate posturing, they're defending their core. Even when they're not conscious, right, they get knocked out, they're trying to defend their core. That's better than decerebrate posturing, which is where they start to flare out. When they flare out into decerebrate, they're saying, hit me again, right? Decorticate, at least they're defending themselves subconsciously. Decerebrate, they are no longer attempting to defend themselves. That's another sign you'll see following head injury. And like I said, fighting, usually you'll see that loss of consciousness. That's why they fold up like that, okay? Which is also a sign that people who are professional fighters, there's a reason they have short careers, because their brains take a whomping. Okay, so what does our care for head injuries look like? Establish an airway, control the bleeding, right? Maybe we can keep cerebral perfusion going. Assess their baseline consciousness. ANO times 4 is going to be huge, okay? And if they aren't alert, then we can go through that GCS scale, which I'll talk about later. So manage the airway. If we're talking trauma to the neck, we don't want a head tilt chin lift. Why not? Yeah, we can further damage them. So jaw thrust, that's going to be our choice when we're managing the airway there, okay? Just like so. Put a collar on them. We can still do a jaw thrust with the C collar on, okay? If they have something in their airway, remove it. Remember, we don't blind finger sweep, but if we see it, we can pluck it out of there, okay? Look, listen, feel, check the breathing, and then give supplemental oxygen to anyone with suspected head injury. If they have a head injury, the risk of hypoxia is going up. So we can provide oxygen, which if we think about it, this is where we're going to start talking about potential shocks, right? Neurogenic shocks starting to show up. We got to give them oxygen anyway, okay? If they don't have a pulse, start CPR. If they're not breathing, we're going to bag for them, okay? Remember, blood loss is also going to aggravate hypoxia. Blood carries oxygen. If we don't have enough blood in our body, we don't have the oxygen. And then always control bleeding from the scalp with direct pressure. And then usually with head injuries, it's going to be related to, the shock's going to be related to hypovolemia, right? We're losing volume. Transport immediately. And then Cushing's triad, okay? So hypertension, bradycardia, irregular respirations, which you could see either Cheyne-Stokes or Biot's breathing or ataxic. Those are the same essentially, okay? But manage the shock, oxygen, keep them warm, lay them supine. You can notice Cushing, nothing you're going to be able to do about it, but you at least know, hey, there's something going on inside their head, that pressure's increasing, tell the doctor, they're going to get involved, and they have a whole bunch of whiz-bang fancy doctor things they can do. Okay? For spinal injuries, standard precaution stuff, wear your gloves, goggles, gown as needed. Maintain their airway, right? So we're going to keep them supine, jaw thrust as well, and we're going to give them respirations we can BVM. Remember the two-person technique. If someone's going to be jaw thrusting, you can't jaw thrust and use the BVM. You're going to need to rely on other people, okay? I know if you guys need a break, I can see it. It's okay. Power through. We only have about 25-ish minutes or so, okay? Just hold on for me. So, jaw thrust, manage the airway, consider an OPA. What's a reason we can't use an OPA? Oropharyngeal. Why can't we not use it? Gag reflex. Why can't we use an MPA? What's the reason we can't? Talked about it in the last lecture. Yeah, facial trauma. If there's a fracture or facial trauma, we run the risk of accidentally sending that into their brain, which that's counterintuitive to what we're trying to do, right? Counterproductive. Jaw thrust, once again, we're going to put the C-spine collar on them, right? Now, here's a question. What do? We show up, someone's conscious, and they're holding their head like this. And they say, yeah, my neck hurts. And as we go to adjust it to supine, or to upright, they start to scream. What are we going to do? Do we power through that moment? No. You're going to secure them as best you can in the position found, okay? If someone's neck hurts, don't be the reason that you adjust their head all the way. Now they're paralyzed. Congratulations, there goes your job, right? Make sure you're doing the best for your patient, right? We always want to be patient advocates. So If their neck hurts and they're on the side, you're gonna maintain it in the position found as best you can, okay? We're never gonna force that inline position. We talked about C-collars last time. I'm not gonna spend the time here.
So
Yes?
in that case, like you have a patient who's like their head's like that.
Yep.
How do you like stabilize that? You just hold it?
You can hold it and then pat it. Once you get them laid down, pat them with blankets and pillows. That way they're kind of held in that position. Yeah, good question. Okay. So, preparation for transport. Remember, we have to get, when can we let go of manual stabilization? Is it when we have the collar on them? No, what?
When they're secured.
Secured to what? Yeah, the backboard. There you go. Yeah, we can let go of manual when we have secured them to the backboard. Okay, and then remember 4-person log roll. If we're doing the log roll, who's doing the counting? The head, right? The last thing we want to do is to have the person holding the head, and the person in the middle says 1, 2, 3, and the person at the head's like, oh yeah, right? And they're a little bit late on the uptake there, and neck injury, and there we go, problems. Use the vacuum mattress. This is something I haven't seen much. I was talking to some people who do like ski patrol, and they use these a lot. They'll lay them down and they wrap them around a person, and then they'll pull the air out, and it makes it rigid around them. Okay, we have this collar here that's something similar. This is a different kind of C collar. This is one that's not super popular because it doesn't have, or it lost popularity with a few of us because it doesn't have the little windows on it. So I can't see the neck, I can't feel the spine through it, but so that's why we have it here. It's not super popular, but notice how floppy this guy is, right? But once I suck all the air out of it, it becomes rigid. See that? This is essentially what a vacuum mattress does. It's just a bigger version of it. Questions on that at all? Cool. Okay. Sorry, I know it feels like I'm moving fast. I just want to make sure we can get through everything. For sitting patients, it says use the short backboard to restrict movement of the cervical and thoracic spine, and then secure the short board to the long backboard. Now there are some exceptions. You or the patient are in danger, and I'll show you what this is in a moment. You need immediate access to other patients, or the patient's injuries justify urgent removal. Now, standing patients. Yeah, I'll come back to this. So transfer patient to a position in which spinal motion can be maintained. If we show up and they're standing and we're worried about their neck, try and get them to lay down, see if we can get a collar on them, right? Now, clinical indications for spinal restriction: spinal tenderness, altered level of consciousness, deficits, so they're having weird sensation or they're not moving something, obvious spinal deformity, and then high energy trauma in an intoxicated patient or one with a distracting injury. So another story. Working East Boise, dispatched to Lucky Peak, the reservoir, for an ejection from a vehicle. When we show up, the back window, so the guy, passenger went through the back window, rear passenger window, and when we show up, the driver's there. I was like, hey, where's the patient? He's like, I don't know, he's walking around here somewhere. It's like, okay, well, sure. So I go and find him. Sure enough, he's walking around, standing, talking. 1, speaks Russian only. That was difficult. 2, we have no cell service, so there's no translating my way through this. So I finally convinced him to lay flat, get a collar on, and he's fighting me. He wants the collar off the whole time. He kept saying something over and over and over. And then once we finally get into cell service, I realize he's asking for water because he's dehydrated, which makes sense, right? So he's still fighting me for this collar, and I tell him to finally leave it, and he does. Now, later, we drop him out to the hospital. About 2 hours later, me and my partner were back there, and we're cleaning a gurney off. And that patient comes walking around, and he's not wearing a collar at this point. And he asks for a bathroom, which my first thought was like, so you do speak English. Not happy about that. But second was like, maybe you should go lay down. And then we pointed him towards the bathroom he can use. He went that way. As soon as he left, a nurse came running around the corner. I was like, where is that Russian-speaking guy? I was like, oh, I directed him to the bathroom. Why? She's like, oh, he has a C2 fracture. So he broke C2, but he's up and walking around, right? So presentation necessarily doesn't mean they're not having a serious injury involved. Does that make sense? Everyone kind of see why from that story? C2 fracture is a big deal because if you break above C3, you stop breathing, right? So just because they're standing, walking, seem fine does not mean that they're fine, okay?
If they're standing up,
No, if we've ever done a standing board. No, we don't do a standing board. It's going to be more so of like if they're standing, let's just bring the gurney so we can get them to sit, and then we'll help them transition to the laying position. Yeah, it's not going to do them any good to hold the board and then like timber them down. That's too many variables with increased liability. Yeah, good question though. Okay. Go ahead. So spinal immobilization devices. Assume the presence of a spine injury in all patients who have sustained head injuries. Read the mechanism. And then manual inline stabilization for a C-collar and long backboard, right? You have to hold them till then. Now, when I say short backboard, this is what I mean. This is a device called the KED, the Kendrick Extrication Device. This is the least used piece of equipment on any ambulance. Reason being, it takes way too long to get it on. The thought is, if we have a driver who's got a potential neck injury, they're leaning forward or they're in their driver's seat, we're gonna have them, one person in the front, they're gonna lean into us, the person behind them is gonna shimmy into this hopefully not destroyed car, drop this behind them, the head goes up here, this strap will wrap around the torso, and then there's these two bottom straps. So once we have them there, and they're gonna be in a collar at this point also. You're gonna strap their head to that, and then you're gonna strap these around their waist, and then you're gonna bring those up, and you're gonna basically wrap it under their butt, and then strap them in so that we can grab them and pull them out, and it's gonna keep them rigid. It takes way too long. It takes way too long. If we have someone unconscious in a vehicle, unresponsive, leaning forward in the driver's side, an urgent or emergent move makes way more sense, okay? Not often are we gonna have the time to be like, yeah, they look pretty bad, get that out, it's gonna take 5 minutes, right? We're not gonna waste the time doing that. I've only ever used this one time, and it was for not what it's designed for. I ended up flipping it upside down and put this around their pelvis. This was down by their feet. It was for a kid at a local high school that has an automotive shop. He was dragging the engine winch for the auto, and it caught the double doors that had the middle metal pole. It caught the little metal thing on the floor that the pole inserts into, and it fell and ended up cracking his pelvis. So I was like, well, let's flip it upside down and use it as a pelvic binder, and it worked great. But that's the only time I've ever used it. And the only reason I used it is because a fire captain was like, can we use the KED? I've never used it before. And he was like a 15-year captain. So keep that in mind, okay? And that'll be a question you'll see. Why do we not use the short backboard? It takes too long, okay? Long backboards, we talked all about them with lifting and moving. Do I need to go into these at all? Okay, remember log roll, remember secured, they're gonna have the spider straps. Even the one thing I will say, the scoop stretcher on the left there, in reality, they have seat belts on them as well. So you're just gonna belt them in. That's secured to the backboard, okay?